Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose, put simply, is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. Our community has grown substantially over the past few years. We started in Connecticut, but now have nearly 1,000 stakeholders from more than 40 states all over the U.S. I want to thank our members who make this presentation possible. We'd like to give a special thanks to our trade member sponsor, Connecticut Joint Replacement Surgeons, LLC. I'm joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa Trumbull is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led, clinically integrated delivery system in Connecticut and Massachusetts. Dr. Steve Schutzer, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is the co-founder and president of Upswing Health. Our special guest today is Dr. William H. Bestermann, Jr. Dr. Bestermann is a board-certified internist with over 20 years of experience practicing preventive cardiology. He's the Chief Medical Officer of Epigenics Health and Chief Medical Advisor for Congruity Health. Dr. Bestermann is passionate about healthcare reform that advances evidence-based best practices for managing chronic conditions. He's an ardent proponent of optimal medical therapy, which he writes extensively about on his Substack. Dr. Bestermann authored the first article on a systemic approach to metabolic syndrome and advocates for a comprehensive solution to managing diseases that represent the costliest burden for patients and communities. We're excited to have Bill here today to discuss optimal medical therapy and how this comprehensive approach can improve both clinical and financial outcomes. Welcome to Moving to Value, Bill.
Thanks for the invitation.
So, Bill, I really appreciate you being with us today. I've heard you answer this question before, but I can't help but ask it again, is tell our listeners a little bit about your journey to how you got to where you are today, particularly how you got to focus on, better management of chronic disease. But it's a great story that I'm sure our listeners would love to hear.
Okay. Well, as we discussed, I was the first full-time internist in a little town called Beaufort, South Carolina. And at the time, it was just a sleepy little fishing village on the South Carolina coast, down in the southeast corner across the sound from Hilton Head. But the communities couldn't be more different. Community Beaufort just had a fishing and seafood industry, the Marine Corps recruit depot at Paris Island, and a Marine Corps air station. And that was basically the economy. Now they've got a big hospital with multiple specialties and a robust retirement community. But 45 years ago, it was all different. And I came there as the first full-time internist after I left my service in the Navy. So I served in the Naval Hospital there. And I hadn't really anticipated what was going to happen to me. It was just a little 62-bed hospital. And the closest ICU or CCU was over an hour away on two-lane country roads. There was no helicopter service at the time. And half the people were dying of heart attacks and strokes. So we stood up an ICU almost right away. And I was medical director for 8 years. And so I had to face way too many families with bad news about heart attacks and strokes. Your dad didn't survive. Your mother's not going to be able to talk or walk. And it was really pretty traumatic in a way. And it was very emotional. If you've ever faced a family that loved ones died, that's really traumatic. So I became very, very interested in doing this better almost right out of the gate. And then in the mid 90s, we learned that opening arteries in stable patients, even if you have angina already, that doesn't keep you from dying or having a heart attack, which was stunning to me. I mean, it really knocked me over because I'd sent hundreds of people to have those procedures, to have bypasses and stents. And honestly, few of them had adverse effects from those procedures, and I felt terrible. But the same literature said that best practice medical treatment's the way forward. So if opening that small area of the arterial system doesn't protect you, they said you have to affect the entire arterial system, which involves stabilizing plaque so it doesn't rupture and cause a clot. And then that's optimal medical therapy. And at the time, we understood it was statins and blood pressure control and taking an aspirin and that kind of stuff. But it's dramatically enhanced since then. And that's what I've been involved in ever since the mid 90s, is trying to figure out what is optimal medical therapy, with the key word being optimal. What is the best practice? And how can we actually expand and scale it so that many more Americans have access to it? And if you look at the facts, not very many Americans have access to it. I mean, I can name on one hand the places that you can get truly optimal care. And then that's very important. So one of those places is Kaiser Permanente in Colorado. And they did a clinical trial in which they compared people in usual care, the care that most of us receive, versus those who receive truly optimal medical therapy. And the people who had had a heart attack and were on optimal medical therapy were 10 times more likely to be alive in 5 years,
Wow.
10 times. And it wasn't just cardiovascular mortality. What shocked me, it was all-cause mortality. And I'll just add one little thing at the end. I've written on Substack about optimal medical therapy being that best solution to these chronic related diseases. So diabetes and hypertension and high cholesterol and heart attacks and strokes and heart failure, those things are all related. My favorite measure is the number needed to treat. So how many people do you need to treat to prevent a major cardiovascular event? And so one of the articles I wrote was about that. And so Ozempic and those GLP-1 drugs are all the rage right now, right? They're apparently good for everything.
Yep.
But in order to prevent a major cardiovascular event with Ozempic, you've got to treat 111 people. With Jardiance, it's 43 people. With a statin, it's 35 people. But when you bring best practice treatment of pressure, sugar, cholesterol, taking an aspirin, and not smoking together, the number needed to treat is 5.
Yeah, exactly.
So optimal medical therapy is 20 times more effective and 1/20th as expensive, which is just stunning to me. And why aren't we doing everything we can to scale and be sure that people get optimal medical therapy reliably? And just one more thing, this is where the systems that we talked about come into play. Because if you want to produce a product consistently, you have to have a system to do it. Even if you're making McDonald's hamburgers, to have that same experience in California that you have in Connecticut, you've got to have a systematic way of producing that hamburger. And
Probably should come up with a different metaphor on that one, but yeah, I get it.
Yeah, yeah, yeah.
Yeah.
Yeah, I get it.
No,
But
totally true. We get it. We get it.
yeah,
Totally true. Yeah.
any product, you need that system to produce it.
Bill, let me dive in here. First of all, thanks for joining us today, and also thanks for your service. I forgot that we both started our careers in the military. So I think I mentioned a primary care doc when I started my career in the military. I was stationed in Puerto Rico by myself, so I had to do a lot of reading about how to take care of patients, but it was a great way to start. And it's very interesting, John and Lisa, hearing Bill's why is very similar to Scott Kennard's.
Yeah.
His why was when he lost three people in like 3 weeks. One of them was his best friend that he thought he was taking good care of, but realized he was just kind of checking boxes.
And they were all in their 40s.
And
by
they're
the
all
way.
in their 40s.
Yeah.
Yeah. And that was what stimulated Scott. But let me just dive in for the audience here who may not really understand what you mean by OMT, optimal medical therapy. Can you define that for us?
Sure. So for diabetes, it's achieving certain goals in sugar control, cholesterol control, blood pressure control, while not smoking and taking an aspirin if you're high risk. And it's not just the control level, it's also how you do it. I think the how you do it is almost the more telling piece of it. And so, one of the things I was looking at something about the GLP-1 drugs just before I came on, and it said that they activated a master metabolic switch called AMPK. And AMPK, I know a lot of your people aren't molecular biologists, but I think this is a real easy concept. And so AMPK is a master metabolic genetic switch. And in the fetus, it's critical because if there is no food, AMPK is activated to help the fetus survive. And that's the critical understanding is survival. So it helps the fetus survive, but activating AMPK helps us survive and live longer throughout our lives. And what it does in the fetus is mobilize calories from fat stores and muscle to support the vital organs so the fetus survives until there's food again. And then that survival switch kind of goes quiet when you're a young, healthy adult, and survival is really not an issue. But when you smoke cigarettes or gain abdominal fat, it shuts AMPK down, which is why those people age faster and get sick sooner. But if you activate that with certain medications, you enhance survival. So you oppose the effects of smoking and being heavy, and you do all the things that the GLP-1s do. And so every single intervention that prolongs your life and delays complications in these chronic diseases switches on that survival switch. And I think that's the vital difference. So if you just lower sugar aggressively, there are whole companies in our medical environment that say you can reverse diabetes by diet. But I would say that's not nearly as effective as manipulating that master metabolic switch. So, yes, diet does activate AMPK. Intermittent fasting activates AMPK, exercise, but then ACE inhibitors, ARBs, drugs like spironolactone and eplerenone for hypertension, they all indirectly activate AMPK. Statins do it. Metformin does it. So every single thing that we do not only lowers the risk factor, it activates that survival switch and it protects every cell and organ in the body, which is the key concept and why it's different. So if you look at the CORD trial where they just went after sugar aggressively, using any drug that was approved for the purpose, more people died. They had they had to stop the trial early, and they came to the conclusion that aggressive risk factor control in high risk people was a problem. But that's not a problem. It's how you do it. And if you do it with things that activate that survival switch, guess what? In diabetes, we have absolute proof that you live 8 years longer and your complications are delayed by 8 years. So to me, that's the most fascinating science that I've ever run into. And it's why I'm an older guy who can't, I just love to wake up in the morning and see what's next.
Bill, I think this example is so important because the GLP-1s, it seems, in the medical community and, certainly with patients, have like awoken the industry in a way around how these drugs can be effective in multiple settings for multiple conditions and issues, as you just described. And that's the first time anyone described it to me where it actually makes sense. And so when we talk about optimal medical therapy, how do you know your provider's delivering it? And how does a patient, making it practical for patients and employers, how do they figure out the systems that deliver optimal medical therapy?
That is a fantastic question. And if you look at quality measures, what many people do is they do process measures. Did you measure the A1C? Did you measure the blood pressure? Well, little wonder that those quality improvement efforts don't do a thing. They don't save money. They don't delay complications. They don't do anything. But if you look at Minnesota, Minnesota tracks OMT for every group in the state, and they report it publicly. And so, what percentage of your population achieves the targets for pressure, sugar, cholesterol while not smoking and on a statin? And I think that's the quality measure that matters. If you had one thing you could know about what a group was doing, that would be the one that tells you if they're on it, if they're making a difference, or if patients are getting usual care. And Minnesota measures that for every single practice in the state. They report it publicly. And I don't think it's an accident that Minnesota has the lowest heart attack rate in the country.
Yeah.
If you look at where I live in the South, it's bright red and Minnesota's white. We have many, many people dying of heart attacks, but in Minnesota, it's really low. But the studies that I've been cited were based on the science we knew 20 years ago. We didn't know that using spironolactone and eplerenone had powerful antioxidant and anti-inflammatory effects that ultimately activated AMPK. And so I'm confident that, with the new science and the new understandings, we could really do even better. And if you're in a diabetic family, you've seen all these terrible complications around you. Well, we're in a new day now. If you learn about your illness and you manage it, self-management's really critical. You got to understand your illness to manage it. Odds are much, much better that you avoid and delay those complications.
I want to add on to what you just said because I wish I could share your optimism, but Dean Ornish was writing about this stuff to your point, 20 plus years ago, called with Epstein. We can go down the line. A lot of people more recently, Mark Hyman. I mean, there's a lot of books out there about what we're talking about. There's nothing really new except for, okay, the molecular biology part of it, but I wish I was confident as you that people were going to do it. And I guess the one question is, because part of the problem I think is that, smoking and hypertension and diabetes and hyperlipidemia and obesity, all people feel fine until they die or until they get kidney disease, until they have a stroke, until they have a heart attack. There's no symptoms. So they're not motivated. And part of that ties into health illiteracy, and you've written about this. So where does technology help in patient engagement, patient health literacy, and even the technology of wearables, of continuous glucose monitor, blood pressure monitoring, electronic scales at home? What's your take on the role of those things? Not to take it away from the role of the physician, because I do think the physician-patient relationship is critical, but are those useful adjuncts Because let's face it, doctors have not been doing a good job on managing just plain old hypertension and diabetes in this country, let alone really providing optimal medical therapy for, multi-system diseases. So what's your thought
Well,
on that?
that's another great question, really, because if you look at the concurrent achievement of those five goals that I mentioned, it's about 20%. And if you look at the practices in Minnesota, the performance is very highly variable. There are some practices that are 10%. There are some practices that are 65%. And I will bet you a lot of money that the practices that are doing it at 65% have the systems in place to get that done. So optimal medical therapy is a product, like we talked about. And if you set up your systems to produce that product, you do much better. Nobody's perfect. 65% is a long way from 100%. But if you're at 65%, you're achieving your goals for a lot of things and you're real close to your goals for a lot more. And those patients do much better, and Minnesota does much better. Now, to get to the IT question, if you're just doing a technical thing, you're not going to make a difference. But the technical thing's important because it can extend, it can amplify the impact of the people involved. So it's really great. And I would frame this as high tech, high touch. And if you don't have the high touch piece of this, you're not going to be successful. So I work with nurse coaches every week. I sit with them and we're a team. They call me Bill. I listen to what they have to say about how we can do this better. That's why we aren't really crazy about hierarchy. I want people to be comfortable about telling me how we make progress. But you can have the absolute best recommendations. You can make perfect recommendations. I've been in many physician meetings where the doctor says, how can I be held accountable when my patients don't do what I tell them to do? You can give them the perfect advice all day long, but if they don't trust you, they're going to throw the statin prescription in the trash can when they walk out of the office. And that, I think that's a key factor. But at the same time, I've been working with Justin Davis at Congruity Health to build the IT that supports the high touch. And so we can go to the TPA automatically. It's all set up to be as automated and scalable as possible. So we can go to the TPA, we can identify those high risk, high cost patients. We can identify the people who are not on optimal medical therapy. And then we can serve those gaps in care to the nurse coach for her to discuss with the patient and begin to close the gap. We can provide a care plan to her, and then we can generate a continuity of care document at the end of it all to explain to the other people involved in the care what happened with regard to this gap. And, that's just what we've been doing for 4 years. That's our best shot at what it needs to be to begin with. But we'll be changing what we do as long as we do it, because we're going to learn a hell of a lot more
Right.
as we get involved with more patients about how it all works.
One quick question to loop back to AMPK. I'm just interested. Is that something that can be measured? Is that something you can get a blood test on AMPK and see how you're doing?
Geez, no.
No.
I don't know of anybody that is measuring that.
Yeah, that would be a breakthrough. I mean,
But for example, Ozempic costs somebody $1,000 a month. Metformin is $4 a month. and it directly activates AMPK through the nutrient sensing mechanism.
Yeah.
So the nutrient sensing in the fetus, that's how you know that AMPK, you're not getting any food, so you activate AMPK. Metformin directly affects that mechanism.
To answer Steve's question, I think these are, these genes are there and they're turned on or turned off. I think that's the key. So AMPK,
Right.
mTOR, and again, this was the work Ornish did, with prostate cancer. Jesus, it's got to be 30 years ago now, basically showing how with doing these things like stopping smoking, exercising, a little meditation, relaxation, all those things, getting sleep, you could turn those genes on and off. I think it's not about measuring the level. It's about turning them on and turning them off, turning the bad ones off, turning the good ones on. I think that's the essence of.
That's exactly right.
Bill, you just addressed something that John and I were talking. John's daughter is an APRN who's done some amazing work, and by relationship building, John, you can tell the story better than I can. But I think your systems with involving nurses and PharmDs and such is not just their coaches; they're actually empowered to prescribe, or they're working at really at the top of their license, not just giving advice. Is that right?
Well, that's how you get people to, everybody talks about getting people to work at the top of their license. But, if you empower these teams with IT, one of my favorite articles in all of medical literature is how our current healthcare system fails people with diabetes. And it discusses all the things that we recommend that make perfect sense about how to improve quality. And that is telling the doctor there's a gap, even with adding a solution to the gap, a solution for the doctor, patient reminders. There's a whole list of things that you can imagine. But if you go to how our current healthcare system fails people with diabetes, what they say about the answer to that, it just struck me. And I don't know that this is completely true, but it's true enough. And it said the one thing that seems to work is having teams of nurses and pharmacists operating off a protocol under the supervision of a physician interested in the problem, who are empowered in real time to make adjustments in the prescribed treatment. And to John's comment about Ornish, getting people to change what they do about eating, drinking, and smoking is really hard. But you can have a pill caddy, and all that's real important. And we emphasize it, and lifestyle is critical. But you can impact AMPK medically. There are half dozen drugs that do it, and you can put those in a pill caddy and have it a morning and evening dose, and it's as simple as brushing your teeth, and you can make a substantial difference.
Right.
Phil, I want to get back to something that you said earlier because it struck me as an important factor given the recent influx of technology into healthcare and this concept of high tech, high touch, and the best use of both. I'm sure employers every day look at their health plan. They get asked, to consider a point solution. It's a tech solution, and I often believe a lot of these really don't improve anything. They may get a little bit of a gain at the beginning, but ultimately healthcare is both local and it's personal and it's individual. So how do you know as an employer the best balance of high tech and high touch? And, using the examples that you've raised already, where is the best use of technology? Where is the best use of high touch?
Well, you mentioned employers. And one of the things that we include in our IT program is robust analytics to address clinical and financial outcomes. And as I said, the major clinical outcome is achievement of OMT. And so we provide a dashboard to our employer clients that tells them what their financial performance is, what their clinical performance is, and they can see that at all times. And the best example of a full application of this is a little work site clinic we work with for Vestra Health. And the work site is owned by a casino run by a Native American tribe. So they treat casino employees and Native Americans. And if you look at the care in the engaged patients in the worksite clinic versus the people in the broader community, they can look at their dashboard and they can tell at a glance that those patients are costing half what the community patients cost. And it's because they're in the hospital 1/5 as often, in the ER 1/3 as often. And then the clinic also pulls the other levers they're able to pull, like direct contracting with imaging centers and local health systems and that sort of thing. But there's an organization in the United States providing care for half the cost for engaged patients.
Yeah. Well, the Nuka system in Alaska, same kind of, that's another
They're
unbelievable,
producing,
great
yeah,
outcomes, and
half the
a
cost.
complex, diverse population that's spread out over thousands of
Well,
miles.
and that brings up another point about the IT high touch deal, because Alaska is a problem. There are very few roads, very few railroads, and so it's very hard to travel. And 85% of their visits are remote, and they have community health workers in these remote communities that have an interest in health and blah, 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 but they help coordinate that information technology outreach. But 85% of their visits are virtual. They have quality scores in the 75th to the 90th percentile, and their care is half the cost compared with other
Right.
Alaskans. So,
Bill,
big fan.
once again, there's not a lot new we're talking about, and it's really a failure for us to achieve, whether it's the systems we have failed to build or we failed to measure. As Peter Drucker would say, right, what gets measured gets managed. And you highlighted Minnesota. It's a great example. What do we need to do to convince patients? In other words, instead of saying, oh, you have now your blood sugar's high, I'm going to give you, metformin or glucophage or whatever we're going to give them. Do you talk to your patients about the downstream effects if they continue to do the things they're doing, if they don't manage their hypertension, diabetes, obesity, hyperlipidemia, in 10 years, 20 years, you're going to have a stroke, you're going to be on dialysis. Do you have that kind of conversation with the patients? This is kind of a behavioral economics kind of question, educating patients about the effects of their life path.
So, my most outstanding patient was a gal from Appalachia, very small town in Appalachia, who was 51 years old, and she arrived in my office on a scooter chair. And I devoted 45 minutes for new patients just to get a handle on why they were there and how they saw it. And we had that 45-minute conversation. She was already bad. She had a bad problem. I mean, she was on a scooter chair. If she was on the floor playing with a grandchild, she needed the help of another adult to get up. She weighed about 300 pounds. Nothing was well controlled. And as we talked, she was having a liter of Pepsi and a big bag of chips for lunch. And during the course of the conversation, it came out that she adored her grandson, and he was 5 years old. And we talked a little bit about what it meant to be where she was at that point. And she looked at me and she said, Dr. Bestermann, I want to be at my grandson's wedding. But if I hear what you're talking about, I I don't think I'll be at my grandson's wedding if I keep on like I am. And I said, Well, I wish I could tell you different, but I'm not real optimistic. And so that woman changed what she was doing. She lost 150 pounds. Last time I talked with her was about a year ago. She was a size 8. She didn't use a scooter chair anymore, and she could walk 2 miles in the mountains.
Yeah.
And I actually told that woman, just having my experience with you was worth going to medical school.
Yeah, that's a great story.
You know, it was really, really something. But she had to learn, go
Right.
into the education piece. And honestly, I've been waving my arms, like I said, since 1995, trying to get something going. So 4 years ago, I decided to start writing on Substack about what we've been talking about. And more recently, if you go to my homepage, Bestermann Substack, there are tabs in the header for patient education, student education, if you got a young person who might want to go into health sciences, uh, policymaker education, and clinician education. And I think so much, I agree with you so much about education, that, I've just, that's what I've been working on for the last year, is getting all that in order. And so it's real simple. If you go to that link and you click on patient education, there, of course, there are 15 lessons for type 2 diabetes, hypertension, high cholesterol, and anticoagulant therapy, stopping smoking, depression and anxiety. That's what I'm up to so far. But, I think that a person could go to that as, if you have
Yeah.
if you've graduated from high school, or somebody who's graduated from high school, you can go to those
Right.
patient lessons and get a pretty good idea about
Great.
what you need to do.
Great. Steve, I'm going to give you the last question here to wrap it up, but
No, this has been great, and I'm a big fan. I follow your writings. I don't know how you do it, John, and I will say how you're able to do that once a week is just remarkable. Big fan. Appreciate your contributions. We have a little tradition on the MTVA because we've had some visionary folks like yourself, and we ask you to put your visionary hat on the moment and blue sky thinking. What do you think we're going now, Bill? We've heard this non-sustainable for 15, 18, 20 years, but we know that it really is, healthcare is a mess. We're not, 4.5 trillion now, up another trillion. I mean, what do you think this is going to look like in 3 to 5 years? Just in a broad stroke.
Well, I kind of look at it like a bubble. And I think there are two paths. If we stay on the path we're on, I do what I do because I'm really convinced that it is unsustainable. I believe that. But I also believe that we could follow the evidence and the facts and the science and develop the systems to address all of our health problems much more effectively. We've talked about the importance of obstetrics and how terrible the maternal mortality is in some states. And California has maternal mortality like other countries. So there are examples that this can be done. I mean, the NUCA system in Alaska we talked about, the maternal mortality efforts in California, reporting on optimal medical therapy in Minnesota. In Singapore, they have one-stop primary care clinics. That's their big system. And within those clinics, they have hypertension, diabetes, and lipid clinics. They live longer for a fourth of the impact on GDP. So 5 years from now, my vision would be that every American would be able to identify a place that produced optimal medical therapy and would be able to walk in and be sure that that's just what they're going to get. But this is being done. It can be done. Do we have the will to do it? That's the big question.
Yep, that is a question. Will at every level.
Yeah, indeed.
Yeah.
Indeed. Bill, thank you so much for your time today. I think we could talk to you all day, of course. Needless to say, we have still a long road to travel, but we have the roadmap is there. You know, the template's there, the guidelines are there. We just need to execute, to your point. Put in the systems
Well,
of care, the services around the systems of care. People like the work that Lisa and the SON folks are doing to really manage
right.
populations. People that I see, my own daughter in that practice, you know, her patients are changing their behavior and or becoming more adherent to their treatments because she spends some time with them and they trust her. I think you trust is such a key word in this whole dialogue. That you have to have
It's
the
a key
time
word.
to establish the trust, and the patient's got to know you care about them, not just short term for acute care, but long term to keep them healthy, keep them well, keep them alive, let them see their kids graduate from college and get married. I think that's essential,
Important.
right?
Well,
Yeah.
we've got a mutual admiration society, and I love what the Moving to Value Alliance is doing. And I couldn't be more supportive. I think it's great. I
Thank
Well,
you.
wish you every
thanks again.
success.
And
Yeah.
thanks, Steve and Lisa,
Thanks,
for
Bill.
joining us today.
Thank you.
Appreciate it. Appreciate it.
Yep,
Bye.
Thank
my
you.
pleasure. Thank you.
We want to take a minute now to introduce the new MTVA membership program. As a 501c3 nonprofit, we rely on support from our grassroots network to advance our mission of creating a value-based health system with high-quality patient outcomes at a reasonable cost. As we continue to grow and broaden our impact, we're excited to invite like-minded organizations and individuals to join our membership program. We're proud to offer two membership models, Ally Member and Trade Member. Tax-deductible membership contributions help us enrich the healthcare environment with quality content, including this podcast, and robust platforms to fuel discussion, collaboration, and advocacy that lead to groundbreaking solutions. For more information, including a full list of benefits offered, visit our website at www.movingtovalue.org/trade-member. The link is also in the episode description. Thanks again for listening and for being part of this important movement.